All right, so welcome back. As we move from the hip down, let's talk a little bit about the femur. What we have on the screen here is an anterior view of the left femur. So if this is the anterior view of the left femur, then this is the lateral view. This is the posterior view, and this is the medial view. A couple of things to notice as we kind of walk through this. We've got a couple of things to draw out here. Let's see here. Okay, so we've got the head, the neck, the greater trochanter, and the lesser trochanter. The shaft. We have the medial condyle, and the lateral condyle. Now, if we rotate a little bit around here, there's a couple things we notice. So if I'm looking at a lateral view, we notice that it's not completely straight. In fact, what we have is there's a bow to it. So you think to yourself, why isn't it completely straight? Why does it have a bow to it? Well, if I'm looking at one of the roles that this big bone plays, it's in how it is in it that it manages force. Force coming down from the top and forces rising up from the foot. And as those forces transmit from above and below, if it were perfectly cylindrical and perfectly straight, then it would begin to compress and it would shorten. So it would collapse a little bit. But because it has a bow to it, like this, it still compresses, gets a little shorter. But that energy is transmitted off as heat or it's absorbed because it can always spring back. And so it's a dampener, it's a shock absorber. If you think about it, if you're looking at a pickup truck, the wheels in the back will usually have a leaf spring. So I have a little leaf spring in here. And basically, if you look at it and you flip it up this way, it's a bow. So the forces come here, straighten it out. Forces are released, it bows back. It dampens those bumps that you go along as you go along the road. Well, the same thing here. The curved shape of that femur allows for the dampening of energy. When we come back in the back, there's some pretty important things that we know attach to this bone. Long bone, it's going to have a lot of long muscles that attach to it. But as you're learning your muscles, you'll come across some anatomical landmarks that stand out. And one of them is this right here. It's this line that comes all the way down. This is called the linea aspera. And so you have muscles that have a good bit of responsibility to generate strength coming off of that line. Posteriorly, you can see that the greater trochanters is more pronounced. There's actually a ridge that comes along here to the lesser trochanter. The neck is more pronounced from the posterior view. We notice that the majority, a good bit of the femoral head is actually lined in articular surface. And this is very important because when we think about it, as it fits inside that acetabulum, we know that that ball and socket joint has a high mode of stability. The primary the foundational input for that stability or that mode of stability is going to be bone and how it's created there. If we look distally, some things that we see, if we blow that up, is that the distal femur has two condyles, and it has a notch in between. You can see that big notch. That tells us some things. So as we look at this, that would be our medial condyle, and then this would be our lateral condyle. And so as we can move this up and down, our medial and lateral condyles, why do you think it's this way? Why do you think I need the creation of this space? It's a pretty decent amount of space in there. Well, mainly, we know if I'm putting skin on this, or I'm even drawing the distal extremity on this. So I've got my tibial coming down like this. I've got my fibula coming off like that. And if I wrap that in skin, let's go with this color. If I wrap that in skin, that doesn't leave me a lot of room for things to transmit or be carried in between them. Not a lot of space between skin and bone. And even if I did, if I had arteries that went through here, or veins that went through here, or even nerves that went through here and traveled through this space right here, it'd be really, really dangerous because I could sit down and have a compressive force from the outside and it would squish all of those materials here. And we know that if I squeeze an artery, that it's like a water hose, same thing with a vein, then I'm not going to get a good amount of flow coming out of it. And the same thing with a nerve. If I squeeze a nerve, then I know that that's going to send a stimulus, both this way and a stimulus upstream this way. And that's not something that's desirable. And so I don't want to trap these soft tissue pieces of anatomy within that space. And so what I have is I have this pathway that is created right here. So as I bring it back and look at the posterior aspect of it, now those neurovascular bundles can travel through that space, and they're protected as they travel through that space because there's a tunnel for them to pass through. And that's what we see in the lower femur. The other thing is this, and we'll talk about this in just when we get to looking at the knee joint. If I pull this up and kind of flip it up a little bit like that, I have a very distinct function of this bone. I can put the tibia down here like that. And I know that the function of that joint, the tibiofemoral joint, is to allow this bone to swing up this direction into flexion. We know that it doesn't go into greater extension than 0 degrees. But we do know that it goes up pretty substantially, around 135 plus degrees into flexion. Now, in order to sit down and think that I've got to find stability for that, we think of stability as that general term. What are the threats to stability here? Well, the tibia can slide forward, which means it could come up here, and that wouldn't be a very good move. And the tibia can slide backwards, and that's not going to give me a lot of functionality at the joint. So I don't want it to slide forward, and I don't want it to slide backwards. And also, if I look at it in this other direction, I don't want the tibia. So if we're in the frontal plane here, I don't want this to move in the frontal plane either. So basically, I don't want the ability to swing my legs out like this. I only want the ability to flex my knee. So that means I need to prevent side movement to either side, and I need to prevent full extension. Now, if I look at the setup of the bone, that's not going to happen because bone is not my mode of stability here. Like the elbow stops its range of motion by having this huge olecranon process that juts out. And so when I have the ulna, when I had the humerus and the ulna, that bone provides a block. I don't have that in the knee. So I must rely upon soft tissue. So as far as mode of stability of the knee, the primary mode of stability in the knee is going to be soft tissue. And so when I look at the shape of the femur, having that notch there and these two condyles affords me a greater opportunity to have ligamentous connections that will facilitate the stability that I'm looking for in the knee. Now, the last thing I want to kind of point out about the femur is I want to turn it flat. Maybe we can rotate it around a little bit to see a little bit better. There we go. There we go. It's hard to get positioned just right. Now it's a little bit difficult, a little more difficult than I want it to be able to see this. Maybe this is a better view. Let's try this. So one of the things that's interesting is if I took a line and I drew it straight through, I put half of the femoral head up there and half of the femoral head down here, half of the greater trochanter there and half of the greater trochanter there. I notice if I draw a line also down here through the middle of the condyles, that it's not perpendicular. It's not parallel to that line. It's actually angled to this line here. That means that as we travel from the top part of the femur down to the distal aspect of the femur, there's actually a twist that takes place. One of the things that we're going to talk about when we get to the knee joint is we're going to talk about that femoral anteversion, the femur twist. So I want you to be thinking about what leads to that twist of the shaft of the femur so that there's about a 15-degree offset between the midline of the top and the midline of the bottom. I'll give you a hint. Starts with a W. Relies upon habit, magnitude, force, function. And we'll get back to that when we talk about the knee in general. One more thing. you'll notice in the middle, right here, in the middle, I have a little bit of space that's been cupped out. So there's a recess in here. So as a divot. That is called my fovea. Why is it there? Well, if I drew the acetabulum and then I drew the femoral head, one of the things that's interesting about my femur is it is a long way away from the heart. What does that have to do with anything? Well, the heart pumps blood, oxygenated blood to our whole body. And because when I'm looking at where this is located, the heart's not strong enough because this is all gravity fed. The heart's not strong enough to pump blood through the bone back up into this joint. So what you have to depend upon is a pathway to enter into the top part of that femur so that gravity can fill the leg with blood because we don't have enough partial pressure to perfuse through the bone. So inside of the acetabulum, there's a conduit. It's a ligament. It's called the ligament of teres. And inside that ligament is an artery. And that artery feeds oxygenated blood to the entire bone. Now, this is not a very safe space. Because you've got bone grinding on bone. So if you're soft tissue in between that, it's not a good place to be. It's as good of a place to be between your top line of bony teeth and your lower bottom of bony teeth and putting your tongue in the middle and then grinding your teeth together. It's not going to survive very long. So what we have to decrease this space in here is we actually have a cutout. And because I have that cutout, sorry for a little technical glitch there. So in looking at this screen, what I have here is I have this fovea which is cut out. What that allows is if I have this fitted inside of my acetabulum, like this, that cutout provides me with a space for that ligament of teres to travel. So as this begins to move, which it's a highly mobile joint, it can come forward, it can swing backwards, it can go inside the frontal plane, outside on the frontal plane, and it can also rotate. What this allows to happen for all those motions to occur, but yet I don't grind that soft tissue. So it's a pretty unique design and how that fovea exists in there and that ligament of teres is preserved. Okay, so all together, that is our friend, the femur.